Swinging flashlight test, and by performing a swinging flashlight test we can diagnose the optic nerve disorder. If patient has an optic nerve problem, then it will demonstrate RAPD, that is relative afferent pupillary defect. So the first principle you should understand is that RAPD, or relative afferent pupillary defect, is a pupillary defect where one optic nerve is weaker than the optic nerve. That's why the word relative is there. So if, for example, patient's right optic nerve is weaker than the left optic nerve, and when you perform the swinging flashlight test, you will demonstrate RAPD in the right eye. So the first point is, how do we ideally perform a swinging flashlight test? The first requirement, swinging flashlight test is performed in a dark room. That is very important. The second requirement, patient should be looking at a far object, not at you, not at your face, or not at your torch. The reason is, if he's looking at you or if he's looking at any near object, then he'll accommodate, converge, and the third factor of the near reflex meiosis, so pupil will constrict irrespective of whether you throw a light or not throw a light because of a part of a near reflex. That means you'll be missing out on the presence of an afferent defect if patient has one. So patient looks far in a dark room, use a simple torchlight, and perform a swinging flashlight test. What are the principles? As I mentioned, it is an indication of a relative health of one optic nerve versus the other. So what is very important while performing a swinging flashlight test is you need to make sure that both pupils are illuminated equally. In other words, you need to make sure that the angle of the torchlight for both the pupils should be equal, and the duration for which you will illuminate the pupil for both the pupils should be equal. If you illuminate one pupil like this and the other pupil like this, the amount of illumination which goes through both pupils will be different, and in that case you will not get an accurate information about the pupillary reaction to light. So for principle number one, when we perform a swinging flashlight test, the amount of light, angle of the light, the duration of the light for both pupils should be equal. Typically what I do is I keep a torchlight somewhere here, so you know that the angulation for both pupils would be equal. You can't keep the torchlight here, because if you keep it here, patient will be looking at the torchlight again, the pupils will constrict because of a near reflex. So have a torchlight somewhere here, and in your mind you can count 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3. That's how you swing. Now whether you do it this way or you do it this way, the gap between illumination of both pupils should be equal, and amount of time that the light goes through each pupil should be equal. So by convention, you put 1, 2, 3 here, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3. That's how you swing it. Now, so that's how you perform the test. Now let's say, how do you interpret? Let's take an example and say that patient's right optic nerve is not functioning well. What would you see? So when you shine a light here, 1, 2, 3, the amount of impulses which will go to the brain through the optic nerve would be limited. Let's say optic nerve is damaged 50%. So only 50% of the light which is going through the pupil will reach the brain through the right eye. So you illuminate here, because 50% of light is going through, pupil will constrict. Now you swing it and go back to the left pupil. Remember, left optic nerve is fine, it is normal. So amount of impulses which will go to the brain through the left optic nerve will be 100%. That means it will be more than what went through the right optic nerve. So when you go to the left pupil, it will constrict even more. So now 100% of the impulses are going through the intact left optic nerve to the brain, and that's why left pupil will be constricted more than what it constricted before. Now you have to remember that because of the consensual reaction, when the left pupil constrict this much, when right pupil would have constricted this much. Now you go back to the right eye. Right eye has constricted much more than the strength of the optic nerve would allow. So when you go back to the right eye, now it will start dilating because it has constricted more then the strength of the optic nerve. You go back to the left pupil will start constricting. Go back to the right pupil, it will start dilating. So that's where you say, yeah, okay, patient has a right relative afferent pupillary defect, signifying that the patient has right optic nerve disease. And then you go on to the further investigation, namely color vision, visual field assessment, to come to a conclusion as to what kind of problem patient is having. And after that, you can take a help of an ophthalmologist, neuro-ophthalmologist, or a neurologist to find out what can be done further for the patient. So that's about afferent defect, relative afferent pupillary defect. To conclude, it should be performed in a dark room. Patient should be looking at a far object. The angle of illumination of both pupils should be equal. The duration for which you will illuminate the pupil will be equal in both the sides. And as I said, you come to a conclusion by looking at how the pupil is behaving. You have to understand that when you perform a swinging flashlight test, you're observing the pupil on which the light is falling. You're not worried about the other pupils. You just keep observing what happens when the light is here. Now you go here and say what happens when the light is here. Again, come back here and say what happens when the light comes back to here. And that's, in a nutshell, relative afferent pupillary defect. Now we go to the second part of the presentation, and that is the efferent problem, which is where I'll share my screen and I'll show you some cases of anisocoria, which is the main issue with efferent problem of these patients. So when there is an efferent problem, patient will demonstrate anisocoria. That means there'll be difference in the size of the pupil. One has to remember that in RAPD, or an optic nerve disease, unless the disease is too advanced, there'll not be any difference in the size of the pupil. There'll be difference in the reaction of the pupil to the light. While in an efferent problem, there'll be difference in the size of the pupil or anisocoria. Pupillary size is managed by two systems, sympathetic system and parasympathetic system. Sympathetic system dilates the pupil, parasympathetic system constricts the pupil. So with this principle, that if there is a difference in the size of the pupil, in most instances it is an efferent problem, and the problem is likely to be either with a sympathetic system or a parasympathetic system. Now, how do we come to a conclusion with this? Let's look at some of the cases. So here is a video where you see of the right side, and I'm examining the ocular motility using a torch, and you'll see here that the right pupil is larger than the left pupil. You can see clearly that the large pupil is larger, right pupil is larger than the left pupil. So there is an anisocoria. So when you see that there is a difference in the size of the pupil, the next step is it a parasympathetic problem or a sympathetic problem? To revise, as I said again, sympathetic system dilates the pupil, parasympathetic system constricts the pupil. So what you do next is to find out which condition, which room light condition, the difference in the size of the pupil is more. Is it more when the room light is very bright, or is it more when the room light is not very bright? So when the room light is very bright, both pupils are supposed to constrict. That means that the parasympathetic system should be functioning. But if the difference in the size of pupil becomes more when the room light is very bright, and if one pupil is not constricted, the other pupil is constricted further, you know that the problem is with the parasympathetic system. The parasympathetic system supply to the pupil comes from the third cranial nerve, which is an oculomotor nerve, and that's what this patient had. This patient also demonstrates a little bit of ptosis, and you find that the right pupil, which is larger, and the anisocoria would become more when the room lights are very bright versus when the room light is very dim. So why this is important to know? Please remember, anisocoria, where it becomes worse in the bright light in the setting of the third nerve, is a medical emergency. The reason is, if there is a third nerve palsy, and if there is a difference in the size of people with larger pupils being pathological, that patient can be having a problem called aneurysm. Now that aneurysm can rupture, causing a brain hemorrhage anytime. So if the patient comes to you saying, I'm seeing double, my one lid is a little drooping, if you find that that same side pupil is larger, there is an anisocoria, you need to get that patient in an emergency. Because if there is an aneurysmal rupture, that patient can develop brain hemorrhage, and there is a potential that the patient can pass away if there is a brain hemorrhage. So that's the reason why importance to notice anisocoria and also to examine to find out which system would be at fault. So that's an example of anisocoria worse in the bright light. This is the another example. You have a patient who has clearly, you find that there is a little limitation of the movement, and you also find the pupil is larger. This patient also had aneurysm pressing on the third nerve, and it was repaired, and patient otherwise became better later. Now this is case number 2, where with an arrow I've shown you that this pupil is smaller than the right pupil. You see the right pupil size is this much and left pupil size is a little smaller. And this was the patient who also had a trauma, injury. So again, when you find that the pupillary size is different, the next step is to find out whether this difference becomes more when the room light is bright, or when difference becomes more when the room light is dim. In this patient, the difference between two pupils became more when the room light was dim. And that means the patient had a sympathetic system problem, or a problem called Horner syndrome. This also is an emergency because Horner syndrome can occur when there is a larger vessel which is becoming a little bigger, pressing on the sympathetic system. These patients also can develop stroke very fast. So in other words, we saw 2 examples. Both examples, the anisocoria actually symbolized an emergency neurological situation. And that's the reason importance of examining these patients in a bright room and a dim room to find out, is there any change in the difference in the size of the pupil. If it becomes more in the bright light, you know that patient probably is having third nerve palsy, emergency because it can be aneurysm. If it becomes worse in the dim light, you know patient has a Horner syndrome, again an emergency in an acute setting, because that patient can be having what is called as dissection of larger vessels, which can lead to stroke or heart attack. Last example of a patient where this patient also has a pupillary abnormality. You see this pupil is larger than the other pupil. Also what you'll find is that patient also has a nystagmus, a nystagmus called convergence retraction nystagmus. This patient I am showing you just to say that pupillary abnormality, anisocoria can be seen in this kind of problem. This patient had a problem in an area called dorsal midbrain. He had a syndrome called Perinaut syndrome. So in other words, anisocoria can also tell you a lot about a central nervous system problem. So in other words, please remember pupillary abnormality, 2 subdivisions, efferent and efferent. Efferent, swinging flashlight test, RAPD, tells you about the health of the optic nerve, and efferent, difference in the size of the pupil, tells you about autonomic nervous system or sympathetic or a parasympathetic problem. Anisocoria should be treated urgently to make sure that you find out what the patient is having. I again thank Kapil, Mero Foundation, organizers of AOE, for giving me this honor to deliver this talk. Thank you so much.
Thank you, sir. It was very good presentation.